Get us started. Great, we've got the recording going. So welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Ariana Albanese. I'm an assistant professor in the Department of Psychiatry and Human Behavior at Brown, and I'll be hosting our seminar today. This is the 8th year of our Bridge program's implementation science programming, and we're thrilled to bring these seminars to Providence and the Rhode Island community of implementation scientists, as well as those of you who are joining us from other regions. We're grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advance-CTR, for supporting the technology, logistics, and marketing of these seminars. We also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. And now it's my pleasure to introduce our speaker for today, Dr. Linda E. Guzman, who is a clinical psychiatrist and postdoctoral fellow in the Pediatric Respiratory, Cardiovascular, and Sleep Health Program at Hasbro Children's Hospital / Rhode Island Hospital and Brown University. Her research applies implementation science methods to develop, adapt, and evaluate evidence-based interventions in healthcare settings, focusing on improving the effectiveness and delivery of care. And without further ado, I will pass things off to Linda. You're muted, Linda.
Thank you so much, Ari, for that wonderful introduction, and those who have joined us today. To give me a better sense of who is in attendance, if you are able and comfortable, please share where you are joining us in the chat. For instance, in my case, I would say Rhode Island, USA, and I will add psychologist as my background in implementation science. So I'll just give a few seconds for those who are able and comfortable to please put that in the chat. All right. As those are trickling in, I want to share that I have no disclosures. I'll mention quite a few articles along the way, and I've pulled all the papers and all these slides into one folder you can access with this QR code. Feel free to scan the QR code now or later. I'll also bring the QR code back up at the end. Before we jump into these slides, I want to briefly frame today's talk. Across my work in health systems and implementation science, one theme that has become increasingly central is how active partnerships with communities can strengthen the reach and impact of services. I'll share examples from different settings and patient groups where I've incorporated community-engaged approaches. These projects vary widely in the scope of patient populations served, but show how engagement shaped the direction of the work and the outcomes. As we go, I welcome your reflections, what resonates with your work, where you've seen opportunities, and also any hesitations or sticking points you've encountered with partnering with communities. We can talk through these together, and you're always welcome to reach out afterwards if that feels easier. My goal is to share my path, highlight how iterative community-informed work can be, and offer ways engagement may be integrated. Whether this is familiar or new, I hope it sparks ideas for your own projects. Just to share a brief background of common questions I get during these presentations is, how do you build trust with communities? How do you make sure work reflects community priorities? How do you know when partners have differing priorities? And how do you sustain engagement beyond the project? I want you to keep these questions in the back of your mind and also think about questions that you want to ask. I'll do my very best to answer them at the end with the Q&A questions. Community engagement has a very long history as a field, and in research, it can take many forms. These are just 4 of the most commonly used forms we see in the implementation science space. Sometimes it's built into a project from the start. Other times, it can emerge as partnerships deepen and new needs surface. Engagement can fall anywhere in a continuum, from brief consultation, which is the most common, to fully community leadership, depending on study goals, settings, resources, and relationships involved. Common approaches include consultative, so seeking community input at key points. This could be as feedback on materials, and it's usually targeted expertise with lower burden on the community partners. Collaborative, so the researcher and community partners are involved in the sharing, the decision-making, and refining the work together. Collegial, community members as co-investigators or co-designers of the project, so they may help in defining the research question at hand. And then we have practice or community-led. So research-driven or guided directly by community or practice partners. So this might be when a clinic identifies a priority area and the researcher supports by providing methodological expertise or analytical capacity. Today's talk, I'll highlight 4 studies where I discuss reflections on a range of different community partnerships that have spanned different developmental groups. So I've worked with children, young adults, and families. And my role varied across them from project coordinator to collaborator to research team member. And each engagement shaped the direction of the work and influenced both anticipated and unanticipated outcomes. I'll share what first sparked my curiosity about research and practice informed by community-engaged approaches, how I've led these principles, what has helped me build partnerships, and a few references that guide my decision-making when doing this work. My hope is that these examples spark conversations during our Q&A portion about practical considerations, as well as challenges and opportunities in community-engaged research and implementation. And I feel that to understand my perspective, it helps to know a bit about my training and how I was shaped as a researcher. So as a clinical psychologist, my work has focused on depressive disorders, and I've long centered on how families navigate complex health systems. And then with collaborating in community organizations, it showed me the importance of co-developing interventions that are both culturally grounded and feasible in everyday practice. Clinical work broadened this perspective. Caring for patients with varied histories of trust in healthcare highlighted how evidence-based interventions often require thoughtful adaptation to be acceptable and sustainable. And these experiences prompted me to look through an implementation science lens, one that considers patient needs as well as workflows, staff demands, and system pressures that determine whether an intervention is adopted smoothly or it inadvertently creates new gaps in care, such as only segments of the population receive the innovation. Taken all together, these interests in family dynamics, cultural context, and system-level realities guided me towards pediatric health services, where questions of navigation, trust, and feasibility remain central to my work today. As a psychologist who happens to be bilingual in both English and Spanish and comes from a family with different national backgrounds, I found myself applying research-informed interventions across a wide range of care settings, including Veteran Affairs medical centers, federally qualified health centers, counseling and psychological services, domestic violence shelters, and emergency rooms. Working with a range of patient populations made it clear that even when services exist on paper, many practical barriers may limit people's ability to use them in clinical practice. For instance, I frequently found myself needing to adapt care for patients whose needs were not necessarily reflected in the randomized controlled trials that validated the intervention's evidence. Together, these experiences shaped my research lens and reinforced that improving care system level efficiency requires solutions informed by day-to-day clinical realities and developed in partnership, ideally with the people who deliver and receive care. During my residency year, which is the last year required for the PhD, I learned that it can take nearly 17 years for even a small portion of research findings to reach clinical care. I'm happy to report that it's now reduced to 15 years, but there's so much work that needs to be done. And this delay is thought to be even longer for communities that face substantial structural hurdles. That aligned to what I was seeing as a clinician. This is what drew me to implementation science. The field offers tools such as implementation strategies to bridge the gap or attempt to between what works in research and what can be sustained in day-to-day practice. And it gave me ways to better understand and address the barriers that can make it harder for people to receive care and for clinicians to deliver it. So taken all together, the way I conceptualize myself is that health service work helped me understand needs and where gaps lie. Implementation science helped me feel better equipped to understand how to attempt to close those gaps in the future. And community engagement combined with my own lived experiences as someone who thinks about linguistic considerations to care, the role of geography in informing patient preferences, so perhaps in-person versus telehealth, and experiences trust with healthcare providers significantly shaped my continuing development as a researcher and practitioner. So this brings me to 3 studies out of the 4 that I will highlight in this very moment. The first is a practice and community-led project where I supported recruitment and retention for a co-created intervention developed with and for caregivers seeking mental health services for their children. The second is a consultative study and where I partnered with a Hispanic serving institution in another state to examine cultural factors shaping depression help seeking among college students who self-identify as Latino. This collaboration allowed me to engage with a student population closely aligned with my research question and broaden the perspective represented in the help-seeking literature. And the third is a collaborative qualitative study that explored barriers to depression treatment among Latino adults residing in the continental United States. So, as you can see, each one has a different focus in terms of scope. The first one focuses on a clinic local level, the second one interstate level, and the third one national level. So let's dive into the first study, which began with a simple but important question and complex one to that. And it focused on how we can better support parents and caregivers from different language and cultural backgrounds as they advocate for their child's mental health needs within systems that can feel oftentimes unfamiliar and fragmented for those of us who have resided in the continental states for most of our lives. So parents and caregivers in this setting often encounter linguistic, cultural, and structural barriers when engaging with schools and healthcare systems. So guided by the patient activation framework, the research team partnered with a community mental health organization to co-develop an intervention grounded in families' strengths, priorities, and lived experiences. Together, the clinic and research team hired me as a project coordinator because the role required someone who could bridge clinical, cultural, and research perspectives and/or was willing to continue to grow in those domains. This was my first window into both the promise and the complexity of community and practice-driven work, and it shaped how I think about partnerships today. What is patient activation? Patient activation refers to a person's confidence and ability to manage health, especially when dealing with ongoing chronic health conditions. It includes skills like knowing when and where to seek care, communicating effectively with providers, and feeling prepared to advocate for one's needs during a visit. A strength of this concept is that it's independent of education level and health literacy. And because of that, supporting activation can be a meaningful way to improve treatment access for individuals who face structural barriers, yet remain deeply involved in care. In work by Alegria and colleagues out in Boston, they found that Latino adults with higher activation levels were more likely to feel confident asking questions in clinical settings, especially when they endorse cultural variables such as simpatía and respeto, which means that at the clinical encounter, they might be more deferential to the provider at hand who might have perceived power in deciding or making clinical decisions. Why focus on parent activation? Well, research shows that Latino children's subpar experiences with care are linked to poor social and emotional outcomes across a developmental lifespan. There was initial evidence that strengthening parent activation can improve access, quality, and satisfaction with care, not just for parents or caregivers, but also for their children. Similar to today, there was a mental health crisis. There was a clinic that specialized in providing bilingual and bicultural mental health services. And what I mean by bilingual, in that situation, it was in English and in Spanish. And what I mean by bicultural, it was that to the main US mainstream culture, as well as to the different sub-ethnic cultural affiliations that might exist within Latino populations. And parents were eager to learn more about supporting their child's mental health as they continued to navigate mental health services. So this study, based on this knowledge, had 3 main goals. First, we aimed to identify key informants, those who could speak to patient needs, provider capacity, and research priorities to understand better where those perspectives aligned. So 8 community members were recruited to participate in focus groups to inform our approach. Second, we examined the feasibility and acceptability of delivering the intervention in a group format, which we considered a scalable and promising strategy for building activation skills. The research team met with the clinic executive director and their team to understand their recruitment preferences, clinic workflow concerns, and community considerations, and co-developed a recruitment strategy that balanced the study goals with clinic and community priorities. Third, we evaluated the intervention's efficacy by tracking both participant outcomes and broader engagement metrics. These indicators helped us assess whether the group-based approach led to meaningful improvements in families' lives over time and would enable us to parse out intervention versus group solidarity effects. Looking back, this work most closely aligns with what one might consider a hybrid type 1 trial, one that tests an intervention's outcomes while gathering information relevant to possible future implementation. The focus groups shared long wait lists and a preference for fully Spanish language programming with bilingual staff. The clinic also emphasized that a group format would be the most sustainable model. The final structure reflects those priorities, with 4 intervention sessions delivered by a master's level person, and fidelity was monitored by a licensed clinical psychologist. What I find very interesting is that the idea preemptively was to go with someone who was a master's level. They were already thinking about sustainability post funding from a research study. And so should the intervention be complete and found effective, how do you sustain it post the end of economic resources? And this project ultimately became a randomized control trial of a community-informed parent activation intervention for families navigating mental health in school systems. A parent advisory group, which we call PAG, was built into the grant and compensated for their time. This is the first time I've ever seen this done, but I'm glad to say it's been done more commonly nowadays. And this group guided measurement selection and session content, and their input directly strengthened recruitment and engagement. We enrolled 181 families in a 2-year span, with 92% attending at least one session, and the average number of sessions attended across the intervention and control groups averaging 2.9, which I believe was largely due to the advisory group's influence in keeping the work grounded in families' real needs or realities. Here is the activation scores over time. So the higher the score, the more activated in theory you are. And what we're seeing here is encouraging. Both groups improved over time, but the intervention group, represented by the solid line, showed significantly sharper increase in activation that was statistically significant. This means that parents in the intervention group reported feeling more confident, informed, and engaged when it came to navigating their child's mental health care. We also saw powerful ripple effects from engaging and co-creating with parents. Many shared that they felt more confident navigating care systems, not just for their own families, but also for their children and their communities. The clinic became interested in adapting this group for adolescents, and the research team secured funding to pilot the intervention in an inpatient setting serving youth with more chronic needs. The beauty of community-engaged work is it often grows beyond what one might initially imagine. So now I'm going to shift gears and talk about another study where I applied what I learned from that initial exposure to community engagement thus far to one that I led as a lead researcher using a consultative model. So as you know, I'm a clinical psychologist. I study mood and anxiety disorders, but mostly mood. And I was interested in diving deeper into depression in college students. So let me give some background. The onset of the first major depressive disorder often occurs in late adolescence or early adulthood, which is often overlapping with traditional college years. Depression is the second most common mental health concern among college students, following anxiety. Yet only 33% of college students experiencing depression seek care. And even when prevalence is held constant, Latino students who do engage in care are less likely to receive evidence-based treatments and often face greater challenges remaining in care compared to non-Latino peers. And we know that untreated depression can lead to adverse outcomes. And much of the existing research has examined gender and geographical differences in help-seeking behaviors and intentions, with far less attention to factors such as generational status, sub-ethnic identity, and cultural affiliation, which are factors that may shape how individuals interpret depression symptoms and whether seeking care feels appropriate. So I was interested in how both heritage culture and U.S. cultural orientation shapes mental health perceptions regarding seeking care amongst Latino college students. To give a bit of background, acculturation, when I mentioned that, reflects engagement with U.S. cultural practices, while inculturation reflects maintaining one's heritage values. To do this study, I partnered with a university at a neighboring Mexican-U.S. border town, where 90% of the student population endorsed having at least one parent from a non-U.S. background. And as a bilingual Latina clinician, I often observed how students navigated cultural experiences and language preferences and barriers to accessing support. I noticed that sometimes if a patient had multiple languages, when in therapy, they might express something in one language, and then when it was very emotionally driven, go to a different language. And having that facilitation of being able to discuss one's feelings in the tongue that they prefer seemed important, and that sparked my curiosity. So those experiences led me to focus less on levels of cultural orientation and more on how these cultural processes relate to help seeking. And my hypothesis was that cultural orientation influences intentions to seek care indirectly, mainly through what was perceived as barriers or benefits to services. So let me talk about the procedures and how this was done. This was all through Qualtrics, so it was all data collection made remote. And what happened was students who were in the spring and fall of 2019 academic semesters read a vignette that was validated with a community group first that discussed a college-age student with clinically significant levels of depression. After reading that vignette, participants were asked to complete surveys. One was on the benefits and barriers to seek care, which was established by Vodorick et al. In 2014. The next one was depression, using the PHQ-9, it's a protocol in place to address endorsement of item number 9, which asks about possible suicidal ideation. Then they completed a cultural identity survey, known as the RSMA-2. They talked about their own experiences of help seeking if they had depression or another mental health concern in the past as a yes or no. And finally, they completed demographics. In total, 406 participants completed the project. And here are some results. So consistent with prior research on college students, approximately 1/3 of participants endorsed symptoms of depression at a level suggestive of possible clinical significance. So a PHQ-9 score of 10 or higher. Among those with current or past depression, only 25% reported having ever sought treatment. And in this study, 282 participants indicated they would seek help if they experienced symptoms similar to those described in the depression vignettes. The nice thing is that at the end of completing all the surveys, we had a section where participants could give us qualitative data, where we asked, if you said yes to wanting to seek care, who would you seek care from? And of those 178, 63.1% say they would go to a mental health professional, which we conceptualize as that of a PhD, PsyD, LCSW, psychiatrist, or primary care provider who is involved interfacing with providing mental health services. Now, we used structural equation modeling to look into these variables, but I will sum it in a way that I hope is palpable to the audience. So what we found was that acculturation was not significantly associated with perceived barriers, but it was significantly associated with perceived benefits of seeking mental health care. And my other hypothesis, which predicted that enculturation would be related to perceived barriers or benefits, was not supported. So there was not a significant effect. But my third hypothesis, which was that attitudes towards mental health help seeking significantly predicted intentions to seek care for depression, was. And then finally, significant indirect effects of acculturation on help seeking intentions were found to be mediated by perceived benefits. So moving the needle forward, first, we were encouraged about the findings, but also we encounter limitations. And we looked into the existing measures. So the tools that I use in this research design were not all validated or culturally attuned to the lived experiences of the population of interest. And so I am not yet convinced that enculturation doesn't play a role. I wonder how much of that is related to how it's measured. We need more measures that actually reflect the communities we serve today. So for instance, the barriers and benefits questions did not have culturally informed potential benefits or barriers to seeking care, such as potential benefit of learning how to navigate bicultural processes with a therapist. If that was something that was essential or salient to the participant, it was not included in that. So we may not be capturing everyone's lived experiences. Second, this highlights the value of qualitative data. We need better insight into people's beliefs, fears, and cultural contexts to understand, what informs help seeking, even when it's available. As a reminder, this was conducted on a college campus, and every student involved who were matriculated into the university is offered free mental health services. And so even when services are free, they're not always accessed. Third, students offered practical suggestions to expand the reach of services. So remember that qualitative piece I mentioned earlier? They also talked about what would help to address any barriers that they perceived. And many said, including culturally responsive messaging and orientation about what services are available. If there are bilingual options, if that's important to know, it'd be great to include. In clear communication about confidentiality. Some participants said, yes, I would love to talk to a mental health professional, but I'm afraid if I disclose something that the first response will be to send me to the hospital. So in short, making services available isn't enough. We need to make them approachable and aligned with community needs. And the reason why we might categorize this as a study that was helpful to learn is because we not only captured or reported about what we found statistically significant, but also what might be clinically helpful. Now I move on to the third study, which is a collaborative study. In this one, I want to highlight centers the voices of Spanish-speaking patients and the barriers that they perceive in accessing culturally relevant depression treatment. So to better understand the current landscape of depression treatment, it helps to briefly revisit how language accessibility factors into depression screening practices. So let's zoom out for a second. And in the continental US, since 2016, the United States Preventative Service Task Force, otherwise known as the USPSTF, has recommended universal adult depression screening. And this recommendation was reaffirmed in 2023, citing the PHQ-9, the measure I briefly talked about earlier, as an evidence-based tool appropriate for primary care settings. Although the PHQ-9 has been translated in over 55 languages and validated to be used in Spanish language in primary care settings, the USPSTF guidelines do not reference or link the Spanish language version on their website, despite over 16 million US adults identifying Spanish as their preferred language. And while both the National Institute of Mental Health and the Centers for Disease Control stress the importance of screening in a patient's primary language, this expectation was missing from the USPSTF guidance. This raises broader concerns about bilingual care. And while 22% of US physicians are estimated to speak Spanish at a fluent level, that doesn't guarantee screening occurs in Spanish, particularly in busy primary care settings. And the Spanish language PHQ-9 is less studied in terms of real-world uptake and usability compared to its English counterpart. One possible barrier is a perception that it may lack cultural responsiveness, but it also creates an equity concern. If this guideline exists and is in place to make sure that all adults, irrespective of the preferred language, are screened for depression, but one group is screened at a differential level than the other, despite evidence-informed measure, what is going on here? Those could be missed opportunities for identifying depression. And if depression is identified in a timely manner, treating depression when it's fresh and new, it might be better than when it's chronic and requires more services and potential hospitalization. So this is a key focus of a scoping review I'm currently leading, and the protocol paper is published and also included in the PDF files in the folder. I will revisit the QR code at the end where you may access this more at your own pace. And I want to talk about a qualitative study I led in 2023, and this was 6 years after the initial USPTF 2016 recommendations, where I asked Latino community members and obtained a sample of 50 individuals to discuss barriers to depression treatment and preferences for care. And here's a snapshot of some of the barriers participants discuss. And in case there are individuals on this call who are attending through audio, I will read each one out loud. So let's go with the first participant. Participant 12, female identifying, English and Spanish speaker, age 20, from New England and born in Puerto Rico. They talked about service literacy. They mentioned, I think I have depression, but I don't know any of the treatments or where I would go get care. Maybe I would see my primary care doctor first. Perhaps they could give me a referral or guidance on where to go or where to start. Second is participant number 28, female, Spanish speaker, age 61, from the South and born in South America. They touched upon language barriers, and this is a translation from Spanish into English. Although I am fluent in English, I prefer the provider speak Spanish so that there is no misunderstanding and that all written information be provided in both Spanish and English. Now let's move to participant 1, male identifying, English speaker, age 20, from the South, US born. They talked about geographical location. They said, I think location and provider quality matter most. Some great providers are really far, and others look like they have 4 out of 5 stars. So they were talking about looking online ratings, but they're not actually that good. As you see across interviews, people weren't saying, I don't want care. They were saying either, I don't know how to get it, or I can't get it in my language, or maybe it's geographically far to get. These aren't individual failings. They're structural issues, and they are fixable or addressable. And this study can be characterized as collaborative because community organizations were engaged in multiple stages. So they were helpful in refining the interview questions that were asked, reviewing preliminary findings after the qualitative analysis team ran through a rigorous process, and they were helpful in validating the interpretations. These study results are now published, and also the community organizations that were involved in this process were given kudos and the acknowledgement. And so overall, this created an iterative, co-informed process rather than a research-only model. So you've learned a little bit about myself, what informs the questions I ask and the type of studies I've done. Now I want to talk about implementation science and that lens and how it was helpful in some community-based projects. So my health service work raised repeated questions about feasibility and equity, which naturally led me to implementation science, and which I found gave me tools to further partner with communities and systems to improve delivery in sustainable ways. I realize that not everyone on this call is familiar with what an implementation science does, so let me pause for a moment and bring us all up to speed in the best way that I can. So one thing that we may do is assess gaps related to failure to use an evidence-based intervention. So this might be, hmm, screening is recommended. Screeners exist, but it's not used all the time. What gets in the way? And in situations where it is used, what helps it? Are there preconditions in place that kind of facilitate this process? What could they be? The second one is assign implementation strategies to reduce observed gaps between research and practice. So this might be looking at what could be helpful and testing them out. And usually when we think about implementation strategies, we might have them in a bundle, and they might be low intensity or high intensity strategies. And always consultation with an implementation scientist might be helpful to think through that process. After you've found out the gaps, thought about the strategies, you might want to test those strategies and evaluate the implementation efforts. Were those strategies helpful in, say, increasing the rate of screening? And if so, which populations do we see the uptake most for? And which populations do we notice it not move the needle forward? And what can be done about it? And throughout this whole process, we use a lot of theories, models, and frameworks. And the reason for this is because we want to make sure that all the findings that we learn can be replicable across different settings. Implementation strategies. I mentioned that quite a bit. Let me zoom out what I mean by when I say this. And so say you are in the pre-implementation phase of a research study. You've already identified a gap of what is going on, and you looked at the barriers that are potentially informing that gap. Well, once you've identified the barriers, which you hopefully have used a theory, model, or framework to kind of help you organize that, you might want to look at implementation strategies to help you address said barriers. If you have used the Consolidated Framework for Implementation Research 2.0, you would be very likely using the ERIC implementation strategy, which stands for Expert Recommendations for Implementing Change. What I like about using the CFIR is that the ERIC strategies map onto the CFIR, but you can use the determinant framework of your choice. And after you figured out which strategy you want to use, Rhode and colleagues recommend that you be very explicit in naming that strategy, defining it, and specifying how it's going to roll out. So this would be, for instance, educational opportunities to learn about XYZ. Okay, at what frequency are those educational opportunities? Like what dose? Who is giving them? Who is receiving them? And how are you going to measure if it's helping and move the needle forward? And so all of this could be useful in creating a tool in action to be implemented. In terms of sample methodological techniques to help with community-engaged informed implementations type studies, I'll briefly touch upon a few. These are by no means a very extensive list. There are so many more. There's like over 200 different types of determinant frameworks. My recommendation is for you to use the one that makes most sense for your project. Here I list the CFIR 2.0 because I mentioned it before, but there's also the IPARIS. And then there's also the Health Equity Implementation Framework that was an extension of the IPARIS, but which I highly recommend because it also includes 3 domains related to the social determinants of health. And so if doing implementation science work and looking at health disparities and also community engagement, I would highly recommend looking into the Health Equity Implementation Framework developed by Woodward et al. From the University of Arkansas Medical Sciences to help with that process. If you are going to do an implementation science, highly recommend that you use the implementation research logic model developed by Smith et al. And basically, this helps you map out a priori, what your determinant framework is going to be, what the barriers might be, what are your hypothesized mechanisms of change, which strategies you might use to address those, and what your intended outcomes might be. Your outcomes might be at the intervention level, at the implementation level, at the patient level, but helps you think about what questions you may or may not be asking and what you would like to ask. And when working with community partners, sometimes coming into a meeting with such a model helps you see where you might be overlooking or you might want to expand your work. Barrier identification and prioritization could be done in so many different ways. And one way that's commonly used is using key informant interview developed guides of sorts. And another thing to do is if you were to go that route, you could use rapid qualitative coding. So in the drive, I'll have an article by Hamilton et al. Out of UCLA who describes the rapid qualitative coding method. But you may also consider using a rapid ethnographic assessment, which uses a combination of surveys, clinical observation, and other methods to get at the non-specifics that are hard to capture through regular quantitative surveys and qualitative interviews. Then we have implementation strategy selection. And one way to do this is using a using a process called causal pathway diagramming. And if you look through the advanced Rhode Island CTR videos from 2024, there was a talk describing just that and how one might do this. And then adaptation frameworks. Perhaps you're not interested in looking into adapting an implementation strategy itself, but an intervention to make it more culturally appropriate. My recommendation, and that of many others, is to document why you made changes to the intervention, why you hypothesize those changes are necessary. And different ways to do it is looking through the frame-IS, adapt it, or the adaptome as ways to make this more transparent so that others can benefit from the knowledge base you're creating and for it to be replicated and benefiting a wide range of individuals. This is a great tool to look at the community engagement implementation science phases. So if you're the pre-implementation phase, things to consider in terms of community engagement. If you are in the implementation phase itself, similarly, the same thing, or in the dissemination and sustainment phases, what might consider. This brings me to my last case example, which is a collegial example, and it was testing a produce prescription implementation blueprint to inform food security. In the words of implementation scientist Curran et al., the thing in this case was VeggieRx. To give some background, food insecurity means unreliable access to enough affordable, nutritious foods. Around 1 in 10 US residents experience it. COVID-19 increased these challenges across many communities. And now with what's going on with SNAP benefits, it's back in our minds in the forefront. Nutrition security looks not just at access, but also at the quality, affordability, availability, accessibility, and safety of foods that support health. And the pandemic underscored gaps in both food and nutrition security and highlighted how local health systems can play a key role. We have a paper that has been published that was a protocol of this study. It's also included in the file that I am sharing. And in the words of a colleague, they had mentioned that long-term solutions require addressing the root drivers of poverty and creating sustainable ways to increase access to nutrition and community-informed foods. So this study had 3 aims. So identify determinants. By now, hopefully, you know that you can do this through different frameworks, such as the CFIR 2.0 or the Health Equity Implementation Framework. Select and tailor implementation strategies through community-informed process, and having enough data to potentially think about piloting a hybrid type 3 study, which focuses on not just the implementation of this intervention, but also in collecting information about the implementation strategies that could be helpful. Step 1, barrier prioritization. So we decided to use the method of qualitative interviews. We interviewed 3 segments of the population, those that had participated and those that had not participated in terms of eligible participants, eligible prescribers, and third-party vendors. We used a rapid qualitative analysis method, and through that, we generated a list of barriers and facilitators. Here are some quotes of what participants said. For the sake of time, I'll just read one. And it said, "I got fresh fruits and vegetables, and I did not have to go to the store. It was like Christmas every time I received my vegetables." In terms of barrier prioritization, which was step 2, what ends up happening quite often is that you'll have way more barriers than are feasible to address. And this could be very unsettling for community partners and researchers. In our case, we had 42 barriers. And what we did was a collaborative sorting process. where our community advisory board in real time ranked these barriers based on two factors, importance and feasibility. And those in the first quadrant were the ones that we focused on. Steps 3 and 4 were implementation strategy, prioritization, and selection. So we provided the community advisory board with the ERIC strategies, but also had them generate an initial list of what they thought would be helpful. And then similarly, we ranked the implementation strategies based on high impact and high feasibility. So we had 2 rounds of ranking. The first one was feasibility. As you can tell, a lot of them were thought about as high. And then the second ranking, those that were in the high impact program success were selected. So there were 13 total. This led to an implementation blueprint creation. We're very specific on what the implementation strategy was, who, when, and study phase. And all of that is under review currently and hopefully will be published soon. Examples of implementation strategies, because I realize we talked a lot about them, but this is how they might look like in everyday practice. So a lot of participants said, we love that we get the vegetables, but we're really unfamiliar with some of them. So why not create a tool to help us with that? And here's an example of what each participant would get with their vegetables. Some said, yes, we were able to get, referred, pick up the vegetables, but we don't really know how to use them as intended. It would be very helpful for us to have, say, a list of recipes in our preferred language about how one might do that. And here's an example. Third, we had, feedback that getting information about how to properly store food would be helpful so that we can be using them as intended. And then from the clinic perspective, making workflows in a way that could help with expanding the reach of not only identifying those who could benefit from the program, but also referring them to appropriate services. If we think about resources that could be helpful when doing community-engaged implementation science work, here are just a few resources I recommend. So if you are in the pre-implementation phase, using a determinant framework to look at barriers of facilitators might be helpful. In this case, the Health Equity Implementation Framework might be one to consider. If you are in the pre-implementation phase and you're just thinking about a study and you want to do it from the ground up with community partners, consider looking into the Transcreation Framework for Community-Engaged Behavioral Interventions to Reduce Health Disparities. It gives you a 7-point guide of how one might go about this. And if you're looking at the evaluative stage of an implementation effort, consider looking into the extension of RE-AIM. If you are thinking about where you lie in the continuum, if you are thinking if community engagement might be the way to go, look into potentially sitting privately and what questions might come up for you. Maybe ask a trusted peer about things to consider. If you're fortunate to be in a group, ask about if they have memorandums of understanding when partnering with communities to help look into things such as power and privilege and how those might come up. And always consult with those who you feel comfortable with and also might want to, grow in your understanding of. Adaptation frameworks, oftentimes we might have to adapt those interventions that exist. Here's a recommendation of a model to consider. If you are adapting an implementation strategy, look into the Frame-IS. And for study designs, you might consider using a sequential multi-phase assignment randomized trial or multi-phase optimization strategy, depending on where you are. So in summary, I know I've gone through so many different topics and different experiences, but my hope is that this was an opportunity to think about where you might lie in the continuum, see that it's a process. I'm still learning myself, but I really appreciate your time and consideration for today. And I want to briefly acknowledge that it takes a team to do such work. And thank you everyone who is on this list, but also those who aren't, for helping me do this work. And I'm deeply grateful for their partnership. As promised, here is information regarding all the slides and references I have. And thank you so much.
Thank you so much, Linda, for that presentation. We do have a few questions in the chat already. So one, and this was put in the chat pretty early on in your presentation. I think it was part of your background, and I understand you may not have this offhand, so maybe we can talk about another way to get this information out. But someone was asking about the reference for the 15-year update for the gap in translation. Do you
Yes.
happen to have that
I
handy?
do you have that reference? It is in the folders I created.
Oh,
If that person feels comfortable, please shoot me a direct email. I'm also happy to directly email that reference to you anytime.
okay, great. Would you mind just popping in the chat the just like the folder or like maybe putting up the QR code just so they can snag it right now?
Of course.
Um,
Yes.
okay,
Thank you.
awesome. Great. Um, and maybe I'll just give you like a beat to do that. And then we do have a few more questions coming in, as well as kudos for a really excellent presentation.
Oh, well, thank you.
So let me know once you've kind of gotten a chance to do that, and I'll jump into the next question.
Great. So I am going to put in the
Perfect.
code for the
Okay.
whole folder, and in there, it'll be one of the many files included.
Great. All right. So another question that we have, um, this person, so it's Dr. Hannah Frank, our colleague, is mentioning that there is sometimes an assumption that more in community engagement is better. Um, and there are times when different levels of involvement might be kind of more or less appropriate. And sometimes community-led partnerships may not be the most feasible or like what's of interest, even kind of from the community standpoint. Can you talk about what you consider when deciding the degree of involvement for community members in a new project? Like, how do you think about that or hold discussions?
Yes, I really love that question because it takes into perspective so many varied dynamics that are happening in relationship building. And also where we stand as researchers and practitioners interested in doing community engaged work. So oftentimes we also have to check our bandwidth of where we are in a career and what's available to us and how we can sustain being in places where we're going to be able to continue doing good work. And sometimes that might mean that community engaged type of work isn't feasible at that time, but it's something that you always think about in your background. And in certain occasions, it may not be the thing to do at that time. Maybe because you might need to further develop the community partnership or the research question that you have at hand doesn't lend itself necessarily to community engagement. But one thing that I would always say is regardless of where you are on the continuum and if it makes sense to do community engaged work or not, one thing that I didn't mention is dissemination science. And so one way to always stay connected to the community is even when you're doing work that is maybe not community informed or led, being able to disseminate your science to the community at large helps build with trust of you as a researcher and helps reduce that gap between what is created as evidence and what the community could apply. So it's a long-winded response that I myself am still grappling with, but I appreciate the question and consideration, and I'll think about it more.
No, I appreciate that answer of, I think an important message you're saying there is even if in this moment or in this context, it's not the time, always kind of keeping in mind where there may be, a kind of better fitting time in the future and really prioritizing centering those voices. That makes a lot of sense. So this next one is an awesome but a really big question. So if I want to develop and pilot a behavior-informed intervention to tackle and end disrespectful maternity care in Uganda, what advice would you give? Maybe I think there's it's a great question. There's a lot you could say, but maybe like how would you suggest this attendee start to think about it? Maybe even like formulating their research question. Um, where would
Yeah.
you start?
Well, one thing that I would start with is thinking about the concept of respect. You know, I might think about the denotation, the connotation of that word, but also the denotation of it as well. How do I interpret respect? How does the community interpret respect? And start to think about where there is alignment and disalignment, and if it's prudent or not for me as the researcher to be the lead interfacer of this conversation? Or would it be better served to have a community member who feels empowered and well adequately supported to lead these conversations, just to gather a sense of, what the pulse is like in that setting, why it's coming up, people's interest to address it, and if so, what the community think is the most reasonable way to go about it. Because oftentimes communities have their solutions that they're curious about. Um, and so being able to capitalize and being supportive of that could be helpful. And so what I'm talking about a lot is the pre-implementation side of it, even before designing a study, thinking about what opportunities lie, what's feasible, what capacities do you have, resources are at hand, and what makes sense at that time. And then collecting sort of your arsenal of what you think you will need and what community partnerships you might be able to foster. I also want to admit that it's not a content area of expertise, so I would also make sure that you consult with someone who is very actively involved in this space about things that I might be missing as I conceptualize this. But thank you
Thank
for
you
the
so
question.
Yeah, thank you so much for that response, Linda. So many good points you made. I think some, big takeaways are, kind of thinking about what are, and we might call these like the practice-based evidence or like the ways that the community is already approaching it. Thinking a lot about kind of your positionality and am I the one to take this on? If not me, who? And if you are the one, even still kind of thinking about who's important to bring in on that team. So thank you. Thank you so much. Um, and maybe one last question that just came in because we only have 2 minutes left in our time today. There is sometimes pushback to community partnered work, saying they often don't know what they need, and we need to step in and tell them what they need. Do you think this is true?
There seems to be a lot of nuance in that question. And I sometimes think about where I was in my journey. When I was first originally doing community-based work, I was also doing implementation science work, but I didn't know it yet because I didn't have the vocabulary. So oftentimes, maybe the community partner has an idea, but maybe they're using different vocabulary than, say, the researcher. And oftentimes, if they are coming to the table with an idea, it means that they're open to the possibility of exploring it together. So I would focus on building that relationship, understanding what motivates them to that idea, because there's something there that's bringing them to the table, and kind of take some time to do due diligence and think about what those factors might be to further explore that together. And I realize that we're close on time, and I want to make sure that we're able to also announce the other speaker coming in.
Yeah. Thank you so much, Linda. Uh, thank you for this fabulous presentation. So we want to remind folks that next week we will have Dr. Sophia Bartels. This is rescheduled from an earlier week, presenting on optimizing the development and tracking of implementation and sustainment strategies, lessons learned from 2 large-scale implementation science studies. And we also ask that you please fill out the evaluation if you have a moment. We really value that feedback. Well, thank you all so much. Thank you, Linda, for a fabulous presentation, and we hope to see you all next week.